Good morning, good evening, and good afternoon, depending on where in the world you are. Welcome and thank you for joining us here today for the start of EMPHNET Regional COVID-19 Operational Research Symposium. I am Adna Maita, the Capacity Building Officer of EMPHNET, and I have the honor of opening this very important symposium. And now it is my great pleasure to hand the microphone to Dr. Muhannad Ansur, the Executive Director of the Eastern Mediterranean Public Health Network. Dr. Ansur has been instrumental in shaping the response of COVID-19 at a global and local level. And here at our organization, we're personally grateful for him for his leadership in leading GHD EMPHNET and guiding us through this pandemic. Dr. Muhannad, the floor is yours.
Thank you very much. Dear colleagues, honorable guests, good morning and good afternoon and good evening. It's my pleasure to be here with you today, and I welcome you all to EMPHNET Regional COVID-19 Operational Research Symposium. After months of conceptualizing and planning, it's an honor and privilege for us at EMPHNET to see the first edition of this event come to life. Today, I confidently say that I see the 2 days come offering important sessions that will shed light on the latest scientific findings from the region regarding COVID-19 pandemic and public health. This symposium serves as an ideal space for the Fgtp field epidemiology training programs, residents and graduates from our region, as well as public health professionals to share their experiences dealing with the critical issue at the forefront of public health. I see the sessions that follow serving as a hub for everyone presenting at this symposium to share their achievements, research findings, and field investigation on COVID-19 and public health with a wide participation base. One of our main aims from this event is to showcase COVID-19 related work from Eastern Mediterranean region, as this symposium grants well-deserved recognition to the FETB's field work, as well as the work of other public health professionals in the Eastern Mediterranean region through its diverse agenda. I hope that you use this time to engage in discussions that may lead to contribute to advance COVID-19 research agenda and public health in the region. Holding the theme COVID-19 in the Eastern Mediterranean region, epidemiology, impact, and lessons learned, the symposium offers everyone present the opportunity to share work that COVID-19 pandemic has made more obvious due to the high risk it poses to health workers across the globe. The lessons learned from this pandemic are hard-earned, vital, and worth sharing. They define the experience that ought to guide the public health community toward success in similar future situations. I can say that the meeting here online and being able to bring together experts from around the region and the globe is indeed a silver lining to an otherwise very challenging year for the global public health community. Presentations shared during this event are made by teams of public health professionals and field epidemiology training graduates and residents from different countries across the Eastern Mediterranean region, including Afghanistan, Bangladesh, Egypt, Iraq, Jordan, Morocco, Pakistan, Saudi Arabia, Sudan, Tunisia, Yemen, Palestine, Iran, and others. We thank everyone presenting in this event, and we thank everyone joining us. I do look forward to hearing what insights the discussion made over the 2 days that follow will add to the global discussion on COVID-19 research and public health. I also want to sincerely thank the Director for Information, Evidence, and Research at WHO, IMRO, Dr. Arash Rashidian. And allow me also to welcome our colleague and friend, Associate Director for Science at the Division of Global Health Protection, Ronald Molinar, for being with us today and for enriching our agenda further with keynote addresses that are sure to enhance our knowledge. Finally, I want to thank the moderators, organizers, and the scientific committee members with us today. Their contributions to our event are truly vital. I leave you with sincere hopes that you find in it a beneficial experience and an introduction for further discussion and collaboration to come. Welcome once again, and let our fruitful exchanging begin. Thank you very much.
Thank you, Dr. Muhannad. And now it is our pleasure to show you a short movie that highlights all the hard work that FETPs have been doing during the COVID-19 pandemic.
Since early December 2019, COVID-19 has evolved from an isolated disease born in Wuhan, China, to a global pandemic that has spread across the world. From that day onwards, COVID-19 has continued to challenge health systems while bringing the world to a standstill. On the 30th of January, the World Health Organization declared COVID-19 as a public health emergency of international concern. It was around that time that the pandemic started affecting the Eastern Mediterranean region. On the 14th of February, Egypt confirmed its first COVID-19 case. Iraq and Afghanistan confirmed their first cases shortly after that point, more specifically on the 24th of February. On the 26th of February, Pakistan confirmed its first cases. Then by the 2nd of March, 4 more countries in the EMR confirmed their first COVID-19 cases as well. On the 8th of March, Bangladesh reported its first cases of COVID-19. And by the 11th of March, the World Health Organization declared COVID-19 as a global pandemic. Shortly after that point, on the 14th of March, Sudan also declared its first case of COVID-19. Yemen was the last country in the EMR to declare its first COVID-19 case on the 10th of April. To this date, these countries collectively reported a significant number of positive COVID-19 cases. As the pandemic evolved, residents and graduates of field epidemiology training programs, or FETPs, started gaining prominence, and their role in the COVID-19 pandemic response intensified. With the widespread of the pandemic, their efforts magnified to investigate, detect, respond to, and prevent this threat.
FETP residents and graduates during the COVID-19 pandemic reflected commitment to assuring delivery of essential health services while working persistently to prevent and control virus transmission and educate the public. They put their lives on the line for the overall benefit of their communities. The crucial contribution and sacrifices that they provide are worth our admiration and appreciation.
In responding to the COVID-19 pandemic, FETP graduates and residents were involved in multiple activities, including needs assessment, case investigation, points of entry screening, isolation protocols, transferring cases, contact tracing, risk communication, community awareness activities, infection prevention and control training, amongst others. While people around the world were advised to stay home, FETP residents and graduates were in the front lines, spending days and nights in the field to respond to the widespreading pandemic. FETP residents and graduates across the Eastern Mediterranean region were involved in needs assessment and case investigation. They were successful in spreading knowledge in their communities. They were involved in risk communication and community outreach activities. In this area, they also developed guidelines for testing and the management of false information. FETP residents and graduates also participated in health information management within their country's health systems. They contributed to enhancing and updating national surveillance systems and developed COVID-19 case definition in accordance with the World Health Organization guidelines. They have also been involved in analyzing relevant data, all to offer informed recommendations regarding the management of the pandemic at different levels. They also contributed to COVID-19 operational research with papers published from several country programs. FETP residents and graduates across the region were also involved in scaling up their country's readiness and response activities through conducting training sessions related to COVID-19 management of suspected cases, confirmed cases, and lab tests. They also worked in the field where they had an essential role in surveillance and contact tracing. Despite the continuous rise of COVID-19 cases globally, vaccines are becoming more available in EMR countries, and FETPs hold an important role in promoting awareness of COVID-19 immunization. Throughout the pandemic, they have proven to be an invaluable asset to their country's response efforts, serving as the frontline responders to the COVID-19 pandemic and building health capacities in their countries.
Now, it's my pleasure to hand over the floor to Dr. Firas Salami, the Director of Public Health Directory in Iraq and the Head Community Medicine Department at Baghdad College of Medicine, to introduce our keynote speaker.
Thank you, Adana. Thank you so much, and most welcome everybody. Good morning, good afternoon, good evening, my dear colleagues everywhere. In fact, it is our pleasure today to introduce our eminent keynote speaker for the first day of the symposium, Dr. Ronald Molinar. And Dr. Ronald, he's an Associate Director of Science in the Division of Global Health Protection Center for Global Health at the US CDC in Atlanta. And Molinar has served as the director of the US CDC Country Office and Global Disease Detection Center in Beijing, China. He is a doctor primarily located in Atlanta, and his specialties include general practice, public health and general preventive medicine, and internal medicine. Dr. Molinar holds an MPH in epidemiology and public health policy from the Johns Hopkins Bloomberg School of Public Health, his MD from the Wayne State University School of Medicine, and he holds also a bachelor degree in chemistry from Hope College. In fact, Dr. Ron is not far from the region because he had a contribution in establishing a number of FETPs in the region. At least I know for Iraq FETP, where he works in 2010 in establishing this program. And also he was the editor-in-chief of the prestigious CDC publication, the Mortality, Morbidity weekly report. Dear colleagues and friends, please, if you have any question or comments, you can use the Q&A button down in your screen. And so, because we will have something like 10 minutes to respond to any question or comments after presentation. Dr. Ron, so please, you have 20 minutes, I think, for your presentation. Please, the floor is yours. Thank you.
Thank you very much, Dr. Firas. Good morning, good afternoon, and evening to everyone on the call. It is truly an honor to be with you today. As Dr. Firas mentioned, my background has included a lot of time working with and supporting FETPs and public health bulletins. In the US, we call our FETP the EIS program, stands for Epidemic Intelligence Service, and our public health bulletin we call the MMWR, which stands for Morbidity and Mortality Weekly Report. And so these influences these background experiences will influence this talk. I really want to thank Dr. Firas and Dr. Mohamed for inviting me to speak. Really excited to be here with you. So let me share my screen. There. So the topic I'd like to speak on today is the role of implementation science in global health security. And again, my interest in this topic grew while supporting FETPs and public health bulletins in various countries, including China and India, and then helping Dr. Ferris and colleagues to start a new program in Iraq. And that is when I first met Dr. Ferris. And this is a photo of my first visit to Baghdad, Iraq in 2008. It shows participants in an epidemiology training workshop that was held at the Al Rashid Hotel in Baghdad. Dr. Ferris is in the bottom row, third from right, and I'm in the third row all the way over to the left. And several participants from this workshop then went on to form the first cohort of the Iraq FETP. And I'm very proud of this program and my affiliation with it. And of course, the world has really changed since 2008. And the challenges seem to only be increasing. And today I'd like to share thoughts on ideas of how countries build capacity to protect themselves from health threats, we call global health security, and about a useful branch of science called implementation science and its role in global health security. And FETP programs are critical for both global health security and implementation science. So an agenda for today is here. First, what is global health security and why is it important? A story of unexplained local outbreaks of a neurologic illness in India. What is implementation science? Some examples of implementation science, and then an idea of a catalyst for public health improvement. I hope to share some resources and have some time to answer any questions you may have. So first of all, what is global health security and why is it important? I don't think I really need to share this slide. I think this is something that is our everyday reality. We all know this. The premise of global health security is that in this world of increased travel and trade, diseases can spread quickly from any locality to any place in the world within 36 hours. We're living through this right now with the pandemic.
Dr. Ron, sorry for the interruption. Just to make your slides as slideshow, please. And
Pardon?
Just to make your slides in the slideshow model, please.
Are the slides not showing?
Yes, yeah, we can see only one slide though with the picture only.
Oh. They have moved on my screen, so I'm not sure why they're not moving for you.
Yes.
It is being changed now.
Has it changed?
Yeah, but please make it in a big form, slideshow.
Did you see this slide? Okay.
Yes.
You see this?
Yeah, yeah.
Okay. Right. Not sure what happened there.
Maybe you need to press F5 if you please, Ron. F5. Yeah.
Okay. Well, tell me if
Yeah.
it's showing up on my screen
We
as
see your screen, but it's not as a show of model. So we need to press F5, I think, if you try it, Ron. Full screen, just to make sure that we see the full screen.
and what do you see now? Do you see my slide about why care about global health security?
Yes, but in a small size, not a big screen.
That's really strange.
No, just at the bottom of your screen, there is something just like a screen. You can just press on it. Near minimize enlarge.
That is what I have done on my screen.
Yes.
Let's see. It's not showing full screen.
No, I think
That's fine. We shouldn't be losing so much time on. If it's not going, it's not going.
Okay, I'm
This is
sorry about
okay.
that. It's showing full screen on my slide. So why do we care about global health security? Diseases spread further and faster. According to the international health regulations, 2 out of 3 countries are not prepared. But I think what we've learned from the pandemic is no country has truly been prepared for this pandemic, and all countries have struggled. And then obviously pandemics wreak havoc on the global economy. Global pandemics have a high price tag. Governments in the private sector pay a heavy price through surges in healthcare costs, decreases in travel and tourism, lost business opportunity, and disruptions in trade. SARS, pandemic H1N1, Ebola, Zika, COVID are all very expensive. An early estimate by the World Bank for 2016 puts the cost of Zika at about $3.5 billion US for Latin America and the Caribbean. And the WHO has used IMF estimates and think that the pandemic is costing the global economy about $375 billion a month, and predict cumulative cost at over 12 trillion for 2 years. This might be an estimate. Efforts to build capacity to prevent, detect, and respond to pandemics, on the other hand, are believed to be highly cost-effective compared to the cost of pandemics.
Again, sorry for the interruption, Dr. Ron. If you just click on F5, if you don't mind, just to make it a full screen.
And I'm clicking on F5. Nothing happening on your end, Dr. Ferris?
Unfortunately, no, not yet. So,
Dr. Faris, can we share the presentation?
can we share the presentation from our side, Dr. Ron?
You could. I could email it to you.
Aha, I see.
Hang on. Is it just showing up as a very small?
And it's not moving automatically also. So we missed slide 8. Slide 8 was missed totally.
I do not understand this. It's working on my end.
Someone suggested that you could maybe close down the presentation and reopen it, just to see.
Try that.
Yeah.
Okay. Someone just asked to share my screen. Did that help? Someone has remote controlled into my screen. This is waiting for Aman Narouk to control your screen. Not working.
So far, nothing.
Very strange. I'll try one more time.
Yes, we have it now, but it's still in small size, not a full screen.
I don't understand, but. All right, shall we continue?
Yes, please, go ahead.
Okay. So the slide should ask the question, is global health security relevant for local health threats?
Yes, it shows.
Should show a epidemic curve. Can you see it?
No, go to the next slide. Click on the next slide, we will see it.
Yeah, I clicked on the next slide.
You can just click on it on the next slide in this case. Yeah.
Okay, we're gonna have to try a different approach here. Okay, so this is a slide of an epidemic curve. This was an article published in the MMWR in 2015. And it's about an outbreak of unexplained neurologic illness in a local area of India called Muzaffarpur in the province known as Bihar. And the illness primarily affected young children aged 1 to 15 and usually occurred in the month of June. A typical case would be in a child awakened from sleep around 4 a.m. with a seizure, followed by altered mental status. And this epidemic curve shows about 390 cases in the year 2014, of whom tragically about 31% died. The lab test showed no evidence of an infectious cause, but most cases had low blood sugar. And because of the low blood sugar, treatment recommended included rapid glucose replacement. Very in-depth investigations were conducted by a multidisciplinary, multinational team of epidemiologists, including the Indian FGTP program, toxicologists, environmental health experts, and laboratorians. They looked for heavy metals, pesticides, all were negative, and the diagnosis was a toxic, non-inflammatory encephalopathy. The hypothesis was that this problem had been occurring since it had been occurring every June since 1995, and this was the season for lychee fruit, that lychee consumption might be the explanation. And lychees were known to have a type of toxin in them called methylene cyclopropylglycine, or MCPG, that caused low blood sugar. So they continued their investigation with a case control study and a laboratory investigation of the blood, the urine, and the lychee fruit. And they published their findings in the journal Lancet Global Health in 2017. And they found that 2 risk factors, lychee consumption and the absence of an evening meal, were associated with illness. And they found metabolites of this toxin, MCPG, or a hypoglycin A, both of which cause low blood sugar, in about 2/3 of urine specimens from case patients and none from controls. So they had the cause of the problem was consumption of this lychee fruit. Children who had no other food to eat, gorged on lychee fruit. They had no other source of calories to keep their blood sugar up, and they developed severe hypoglycemia and a toxic encephalopathy. Well, 2 scientists affiliated with the China FGTP observed this paper in the journal, and they did a review of the Chinese language literature, and they published their findings also in Lancet Global Health. And in their review, they found 11 papers, all published in Chinese from 1960 to 2017, that reported on a very similar neurologic syndrome that was believed to be associated with lychees. And they could find literature going back to ancient times about this problem. But beginning in 1995, the print media and local educational campaigns started warning the public of the dangers of lychee disease. And since the year 2000, there had been only one pediatric case and only one death reported in China from lychee encephalopathy. So China or India had nicely characterized the threat and found the toxin, whereas China had already implemented a very successful intervention without knowing the cause. And it wasn't until 2017 that the two independent bodies of local work were put together in the global science literature. So a few key observations from this. First, collaborations can solve complex problems. Local solutions can have global implications. Global neighbors need to learn lessons from each other. Dissemination of scientific information is as important as discovery. And a type of science is needed to understand how to best implement solutions. We call this implementation science. What exactly is implementation science? Well, one definition from the National Institutes of Health is that implementation research is the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve individual outcomes and benefit population health. But I think a more simple definition is simply it's the study of what works to improve health. I like to think of the types of science that contribute to the evidence base for global health security as like three legs of a stool. One type of science is what we often do in epidemiology. It involves characterizing public health threats. But in addition to understanding the incidence and the prevalence and the case fatality rate and the risk factors, it's important to know how do we solve these problems and what are the best solutions, what works and what doesn't work. And similar to that, we have to be able to assess the impact of those interventions. So in the example of the lychee fruit, we needed science to teach us about both the health threats, how many cases and deaths, what is the case fatality rate, what are the risk factors, the source, the natural history, but also about implementation science. What is the best way to educate the public about risks from lychee? Will the community accept that? How can clinicians be engaged? What is the best way to do surveillance for this problem? How should findings be disseminated and how do we measure progress? So what are some examples of implementation science? I want to point to two journal supplements that were put out by our division recently in the journal Health Security. One, and this is an online journal that's open access if you're interested in reading more about implementation science. One of them was about building global health security capacity through implementation science. Another was what works, lessons learned in global health security implementation science. And some of the topics of articles in this supplement include a sample transport system optimization in Mali, public health rapid response team management, and then implementing a global public health workforce target, which asks the question, is the standard one epidemiologist per 200,000 population, is that the right metric? So these are some examples of the implementation science in these two supplements. I have three more quick examples of implementation science that came out recently in the MMWR. And some of these involved either EIS officers, FETP officers, or graduates. First one asks the question, are COVID-19 deaths overestimated in US mortality surveillance? The US leads the world in the number of cases, fatal cases of COVID-19. And many people wonder, is that because we are misclassifying deaths as COVID that aren't truly COVID deaths? This article was published just about a week ago in the MMWR, and its findings were that the findings supported the accuracy of COVID-19 mortality surveillance using official death certificates. They looked at causes of deaths, they looked at the ICD-10 diagnosis codes and concluded that they were reasonable and that the death certificate counts were accurate. And they made the point that high quality documentation of death certificate diagnoses is essential for an authoritative public record of mortality. And this is just an important implementation science for every country. The second example asks the question, do face coverings reduce transmission? We believe this, but back in the summer of 2020, there were still many questions. In this particular study, they found an example of two hairstylists who were working in their hair salon, and both developed symptoms of COVID and were eventually diagnosed and isolated when they came back positive for COVID. But before they were diagnosed, they worked for about 8 days with symptoms. And during that time, they had about 139 clients. And both hair stylists and all 139 clients wore face masks. And none of them became infected, which was very reassuring that face masks do have some positive impact as source control and reducing transmission. A very simple but powerful investigation. The third example is another question that we really wrestle with, and that is, how can schools be reopened safely? They looked at a school in the state of New Jersey that had a comprehensive mitigation approach, frequent testing and universal masking, and they found that it was very effective in stopping transmission. So the last point I want to raise in this presentation is what happens when you combine an FETP with a national public health bulletin. In 1951, Alexander Langmuir started the Epidemic Intelligence Service, the FETP for the US, and at CDC. And Dr. Langmuir was a very brilliant man with very high standards. He was challenging to work with, but he was very much respected for his commitment to excellence. And he noticed a publication which was called the Morbidity and Mortality Weekly Report that was based at an organization called the National Office for Vital Statistics. It was not based at CDC. And he noted that the people who worked with the surveillance data and reported on it in the MMWR did not have any training in epidemiology. They did not analyze the data rapidly or act on the implications of the data. They just reported the vital statistics and the surveillance data. He didn't like that. He wanted the data to be looked at and analyzed and for conclusions to be drawn. So he moved the publication from Washington, DC to Atlanta to CDC so that epidemiologists like those trained in the EIS program could analyze the data and recommend action. And the combination of the two programs, the MMWR and the EIS, made CDC stronger. As our former director, Dr. Tom Frieden, said, MMWR has been a catalyst for public health improvement ever since. These are some resources that you might find helpful to learn more about implementation science. It's the website for MMWR, the CDC COVID website, a global health security website. There's a publication I really like called Science Updates that has summaries of current science on COVID-19 every week. You can subscribe to that and have it emailed to your inbox. There's a guidelines document on national public health bulletins, how to set that up. And then there's a meeting on global health security in Australia that's coming up in June of 2022 that will be accepting submissions for presentations of abstracts that would be valuable for FETP trainees. So in summary, global health security efforts prepare countries to prevent, detect, and respond to threats. Implementation science helps us to implement solutions to these threats. And lessons learned can have timely impact if shared quickly. FETPs have a critical role to play in implementation science and global health security, and the combination of FETPs and public health bulletins enhance global health security. Thank you so much. Sorry about the technical difficulties. I hope this still was useful, and I look forward to further interactions and answering any questions I can. Thank you.
Thank you so much, Dr. Ron, for this very insightful and very fruitful slides. And again, we also apologize for this technical issue to all the colleagues. And the floor is open for any comment or questions. If you raise it or put it in the question and answer box. If you allow me just to, I have a question that had been raised by Dr. Khawaja Mir Islam from Afghanistan. When do you think there is a stop for COVID-19? What actions are still missed?
What actions are still missed to stop COVID-19?
Exactly.
Yeah, I can't speak for every country. I think doing the things we know to do is a big part of the problem in our country. We know we should wear masks. We know we should social distance, yet people don't always do that. And we have problems as a result. We have a vaccine that is slowly being disseminated. And I think there's a lot of what we call vaccine hesitancy. People who have access to it are concerned about it. They're afraid to take the vaccine. It's a new vaccine and it has not been studied for a long time. So vaccine hesitancy is a problem. But I think a big problem is not doing the things that we know need to be done. Social distancing, using a mask, and I think we're all just getting tired. It's been a very difficult year for everyone in every country, and people are exhausted, and it's just difficult.
Thank you. I have another question indeed regarding the implementation science that you described very nicely in this presentation, and that's very, very important area. I think that's how to get use of the evidences that had been found in different publications, different research work, and implement them in order to find solutions and in order to make some change in the field. Well, from your perspective, what works well, what works poor in the COVID pandemic in the implementation side? What do you think?
Well, I'm a little biased, but I think FETPs as a program are one incredibly huge program to be implemented in any country to help solve problems. And I looked at the agenda for this meeting, and I see the volume of good science describing the outbreak, describing long-term complications, describing risk factors for transmission. And I also see examples of what I would call implementation science, where surveillance systems are being looked at and improved, and best practices are being identified. So I think one gold standard positive thing for any country is an FGTP. And then I, just to reiterate the earlier point, I think that there's sometimes a missing link of sharing successful things that work. And we often think that we have to have some sort of groundbreaking discovery that needs to land in the lead article in the Lancet or the New England Journal of Medicine. But simple studies that look, for example, like China, they solved the problem with lychee fruit through a public education campaign. And I suspect there are very many examples of successful interventions in all of our countries that our countries next door would benefit from knowing about. They could try the same intervention in their country, or if something doesn't work in one country, another country can avoid wasting time repeating that same intervention because there's evidence out there that it doesn't work. So the combination of FGTPs, great program for any public health system, and then a way to share these findings quickly, like through public health bulletins. I think those are two great programs that can implement public health solutions.
Thank you. And another question really had been raised by Hannah Taha from EMPHNET. And from your perspective, in your opinion, how was the performance of the global governance of health in handling the COVID-19 pandemic?
I'm sorry, who was, I didn't understand the question.
Sorry. In your opinion, how was the performance of the global governance of health in handling the COVID-19 pandemic? Are you satisfied with the governance of global health in general? I personally have some issues regarding, for example, the nationalism of vaccine. This is an issue really. So from as a professional in the CDC, what do you think?
Yeah, I have to be very careful when I say I could get myself in big trouble. But I think there is room for improvement. I think there's room for improvement. And I think some things have gone well. We all know some things that have gone well. Vaccine rollout has not been great. To begin with, testing did not go well at the beginning. And now vaccine rollout is going better in some places than others. There's lots of work to be done to improve that. I won't say any specific, points about that, but yeah, there's definitely room for improvement. And again, we're all learning lessons here. And this is, to quote a famous author, this is the worst of times, but in some ways for learning and improving public health systems, it's the best of times because we are learning from our mistakes, and there are lots of them, but next time we'll be better at this. So that's one silver lining behind the cloud of this pandemic.
Thank you so much. In fact, we have other questions, but I don't think we have the time to respond to all of these. So I can reassure the colleagues that all these questions are going to be answered later on and can be made through emails sent to you. Yeah.
Thank you, Dr. Fares.
Yeah, thank you so much, Dr. Ron, for your time, and hope to see you again in another scientific event in the region. Thank you so much. Back to you, Dan.
Great to be with you. Thank you.
Thank you.
Thank you, Dr. Ronald, and thank you, Dr. Fares. And now we move to the first session of the symposium, which will be moderated by Professor Salim Adib, who's a faculty member in the American University of Beirut.
All right. Good afternoon, everyone.
Good afternoon.
Very pleased to be part of this symposium. I thank the organizers for inviting me. and I hope that it's going to be a fruitful session. So yes, I'm a medical epidemiologist, a professor of public health at the American University of Beirut. And I'm going to be moderating a session on descriptive studies about COVID-19 in the Middle East, essentially, in the Middle East and North Africa area. We have about an hour to go over 5 presentations. I hope that all presenters are present today. And so I've been very strict on timing. So we're going to try to stick with the 10-minute limit for each presenter, and then we might have something like 15 minutes at the end to discuss what's happening or what has been said. So here we are. We're probably all of us going through the first full-fledged pandemic of our times. I mean, we almost got there with SARS, but it didn't work too long, so we didn't get warmed up to it. And I guess the epidemic of HIV/AIDS is receding in our memories back to the 1980s and 90s. But this one has been quite a serious one, and it has left nobody outside its wake. As of today, we have counted 133 million cases all over the world, and with at least 3 million deaths, which makes it quite a serious problem. But the nice thing is that help is on the way, and I'm glad that Dr. Molinar mentioned the fact that vaccines are finally here and may get us back to some normality. The good news is that as of today, on planet Earth, 150 million people, so more than the count of cases, have already received their vaccination in full. Inshallah, we all get it in all our countries pretty soon. So this afternoon, we're gonna be presenting the situation of COVID-19 in several countries of the region. For now, let's move to a presentation from Iraq on sex-based variations in clinical manifestations and comorbidities still with COVID-19. And this will be presented by Dr. Namir Ali. So Dr. Namir, تفضل, the floor is yours. Okay, we can see the screen.
Good morning, good afternoon, and good evening, everybody. Thank you so much for this. Thank you so much for this wonderful opportunity. Sex-based variations in clinical manifestations, comorbidities, and outcome of COVID-19 patients in Baghdad, Iraq, 2020.
Can you please open your video so we can see a face in the speech?
Okay. Yes. Now.
Great.
Yeah. Thank you.
تفضل.
Background. Over the course of the COVID-19 pandemic, men have tended to have a higher risk of severe infection and mortality related to COVID-19. However, different clinical studies have given conflicting reports on the male or female predominance of COVID-19 infections. This discrepancy is likely due to the lack of large-scale epidemiological studies, socioeconomic disparities, or the prevalence of pre-existing conditions in different countries. The sex-related differences raise questions about the difference in vulnerability, susceptibility, proportion of hospitalization, similarity in symptoms, and response to treatment between sexes. In Iraq, it was reported that a higher percentage of the confirmed COVID-19 cases were males. Other sex-based variations between males and females associated with COVID-19 patients were not adequately explored. In this study, we proposed to explore these associations and provide much needed evidence on the drivers of COVID-19 incidence in males and females. Objective: to determine and compare the variations between male and female COVID-19 patients in Baghdad, Iraq in 2020 concerning the following clinical manifestations, comorbid illnesses, severity, and outcome. Methods. Study design, we performed a records-based cross-sectional study. Study settings, the study was conducted in Al-Karkh and Al-Furat General Hospitals. These two hospitals were selected for the management of COVID-19 patients in the western part of Baghdad, namely Al-Karkh. Although isolation wards dedicated to COVID-19 were added in other hospitals following the increase in the number of reported COVID-19 cases, these two hospitals remain important hospitals for treating COVID-19 patients. Both collectively have 325 beds, including nearly 15 RCU beds. Study population and sampling, we included all the records of patients admitted to these two hospitals who tested positive for SARS-CoV-2 using RT-PCR test in the period of June 1st till August 31st, 2020. The data collection tool was divided into sections. The first section is about the demographics and baseline characteristics. This data collection was developed using the COBA toolbox to gather the information from patients. And we have the demographics and baseline characteristics like record number, date of onset of symptoms, date of hospital admission, sex, age, occupation classified as healthcare worker or non-healthcare worker, and smoking history classified as current smoker or non-smoker. The second section is about the signs and symptoms that included fever, cough, sore throat, nasal congestion, conjunctival congestion, musculoskeletal symptoms, gastrointestinal symptoms, respiratory symptoms, loss of taste or smell, headache. Also included the comorbidities like hypertension, diabetes, coronary heart disease, chronic obstructive airway disease, tuberculosis, asthma, renal disease, liver disease, cerebrovascular disease, malignancy, or others. We also noted the degree of severity of the cases, classified as mild, with upper respiratory disease, or moderate pneumonia, but with no need for oxygen, severe pneumonia and needs oxygen, or critical, the patient needs to be admitted to the RCU. Finally, we gathered information on the outcome of infection, which was classified as recovered, death, and the total number also, we gathered also the total number for days from the diagnosis till outcome, and the total number of days of hospital stay. Now we come to the results. We can see that we identified 2111 patients, 1175 of them were male and 936 were female. There is no significant difference in the mean age between males and females. As you can see, while males have a higher proportion of healthcare workers with 5.6% compared to 3.2%, and it was statistically significant. Males have higher percentage of smokers with 28.9% compared to 7.9%, and female also it was statistically significant. For the distribution of groups by gender and presenting symptoms, we found a significantly higher proportion of respiratory symptoms in female than in male, with 90.5% compared to 87.6% in males. Also, this applies to GI symptoms in sore throat, where we found that 11.5% in female compared to 7.7%, and 14% compared to 10.7% in male. All these figures were statistically significant. For the comorbidity, we can see that 42.7% of female have comorbid illnesses compared to 36%, and this is statistically significant also. We can see that hypertension and diabetes are higher in female with 29.2 and 27.4 consecutively. Also statistically significant, there's statistically significant difference between males and between females and males. For the distribution of cases according to severity, we can see that the least percentage was seen with mild cases with 5.5%, and moderate with moderate cases also seen with and also severe and critical cases. We did not see that there is a significant difference between male and female.
Dr. Namir, you still have 1 minute. I suggest that you go to the essential.
Yeah. For the death, we can see that the case fatality rate was 14.8, 16.1 compared to 13.2 in female. There is a statistically significant difference in the mean number of days from diagnosis to outcome, where it is higher in female than in male. That means female tend to have longer days of disease. For the conclusion, there were some variations between the two sexes in certain clinical manifestations and comorbidities. We saw that, and the severity of the disease and the case fatality rate were almost similar in the two sexes. Recommendations: we recommend that further studies tackling a wider geographical area in the country, and further research is wanted to investigate hormonal, inflammatory, immunologic, and phenotypical differences among COVID-19 cases. Thank you so much.
Great. Thank you very much for a nice presentation and being on time. We appreciate that very much. I've seen Dr. Marcia back on track. So if you can stop sharing, Dr. Namir,
yeah.
We will have Dr. Marcia start her presentation. This is a presentation from Afghanistan. Doctora, ready?
Thank you. Yeah, I'm ready.
طيب تفضلي. The floor is yours. Please put on share your content and put on your video.
Okay.
Okay.
Hello and welcome to today's topic that I was talking about is descriptive coronavirus in Afghanistan.
Sorry, Dr. Marcia.
As all of you know better,
Marcia,
including Afghanistan, because of WHO declared AIDS as a pandemic, and although 71% of
Dr. Marcia, if you can please switch off your video, maybe that will help with the bandwidth. Yeah, I think we lost her again.
Professor Salim, I think we need to go to the next presentation. We have poor internet connection from Afghanistan. I appreciate if we go to Dr. Asim's presentation.
Very well. So we're gonna pass on again on the Afghanistan presentation and go straight to the description of the first cluster of COVID-19 cases in the Sultanate of Oman that will be presented by Dr. Asim. Dr. Marcia, will come back to you. اوكي عاصم المنجي. تفضل دكتور.
السلام عليكم.
وعليكم السلام. هلا. Would you please put your video on and share the content?
It's my screen visible? Or?
Yes.
Yes, you're visible and audible.
Okay, thank you, Prof. Good afternoon, and thank you all for attending my presentations. I'm Dr. Asim Al-Menji from Saudi FTBR2. I will talk about the first cluster of COVID-19 cases in the Sultanate of Oman in Matrah district 2020. I know there is issue is not. Okay. Firstly, I will start to describe Matrah, the district of our investigations. Matrah is one of the 6 districts in Muscat with more than 250,000 people. More than 75% of the population are expatriates. Matrah is the trade center of the governorate, as it's contain seaport, which is mainly function as the tourist port, and also there is old traditional souk, which is mainly the main souk in Oman, which is visited by both the tourists and local people. Matrah also is the home of the private companies and their dormitories for the company employee. And also there is 5 government primary health centers with the expatriate medical fitness center. This is a basic map of the Matrah district, which is so I make the circles like this one. This is the area near to the souk and seaport. This is the area for the new markets and souk, and this is the industrial area. Let's talk about the timeline. On February 24th, Oman had its first COVID-19 cases in the country. It was occurred in Matrah, and it was related to travel to Iran. And on March 10th, the Supreme Committee was established. On 15th of March, the first locally transmitted case in Matrah has been confirmed. And 2 days later, another 2 cases of local transmission has been identified also. On March 20th, we began our field investigations. Our investigations had 4 main objectives. First, to describe the COVID-19 cases in Matrah district epidemiologically in terms of person, place, and time, and also to describe them in terms of clinical representation and outcomes. Second, also to investigate the occurrence of local transmission in Matrah. Third, to identify those risk factors which lead to the spread of the disease. And finally, to assess and guide disease prevention and control interventions that were implemented to control the outbreak. For epidemiological investigation, we focused on case identifications and contact tracing. We described our cases in terms of person, place, and time. And for the laboratory investigations, there was mass testing by the field outreach teams and testing program at primary health centers. For the case definitions, we categorize as suspect or confirmed. Initially, the suspect COVID-19 cases were a person with acute respiratory infection who had at least one of the following symptoms: sudden onset of fever, cough, difficulty of breathing, or sore throat. In addition to the travel history within 14 days before symptoms onset, they had returned from country that had a reported case of COVID-19. On 24th, this definition was changed. In addition to symptoms, travel history was no longer the only requirement of the suspected cases. It's also including a history of contact with COVID-19 cluster 2 or more cases with fever, acute respiratory symptoms in small area like families, office mates, or roommates. Also, the suspected cases, including those who were close contact with the confirmed cases. For the confirmed cases, those who met the suspect case definitions and also tested positive for SARS-CoV-2 by real-time reverse transcriptase polymerase chain reaction. This is for the epidemiological and lab investigation. The active surveillance of COVID-19 cases was done through the Tarassur system, which is the electronic system of notifications and reporting cases. And the patient COVID-19, any patient who develops COVID-19 symptoms will tested and data were entered in the system. And we formed more than 6 teams as outreach team that conducted mass testing, including collecting the nasopharyngeal swab for the PCR analysis. In the field, our team visited the multiple worker deformity to assess potential risk factors. This include housing status, access to the sanitation supplies, and the numbers of the persons. And also we observe any mitigations measures that might be practicing. For the result of our investigations between March 15th and 15th of July, total of 8,400 cases of COVID-19 were confirmed, and the cases before the 15th of March, it was related to the travel. This is the big curve of chart shows the number of COVID-19 cases reported by data in Matrah. The x-axis shows the data of along the bottom, and the y-axis shows the number of cases. As we can see in the graph, the first local cases was confirmed on 15th of March. The case definition revised on 24th, and the lockdown of Matrah district was put on place on 1st of April, and then the active testing increased on 10th of April. Between 22nd of April and 1st of May, there was an outbreak in companies as reported. And the case peaked at the end of May at 1,100 cases per day. The lockdown was partially eased on date of 22nd of June as the cases continued to drop. This bar chart shows the distribution of the COVID-19 cases by age group, as the x-axis shows the age group, while the y-axis shows the number of the cases. The blue bar present the non-Omanis cases, while the orange one represents the Omanis. When we look to this bar chart, it's easy to see that the vast majority of cases occurring in 4 age group, and most cases were between the age of 21 to 60 years of age, and mostly among the expatriate workers, and the mean age was the 37 years. This graph shows the distribution of cases by gender. The majority of cases were male, with less than 15% of all cases being females. Among the male, the cases 85% were expatriate, while for the female cases, Omani women were the majority, 65%. This graph shows the distribution of cases by the nationalities, which shows the 35% of the cases among Indians, followed by the Bangladeshi 33%, and less than 1/4 cases were Omani. This graph shows the distribution of symptoms among the COVID-19 cases, which shows the fever, cough, and sore throat were the 3 most commonly reported symptoms among cases. For the clinical result, out of the total confirmed cases, 7% were admitted to the hospital. 51 deaths occurred for case fatality rate of 0.6%. Only 6% deaths were among females. And more than 17,000 laboratory samples tested were done with a positivity rate of 49%. The positivity rate was high in non-Omanis across all age groups except age group 6 to 20 years. By the nationality, the highest positivity rate was among the Bangladeshi at 67% and Pakistani at 53%. For the environment investigations, I would like to, during the environment investigation, we observed a lot of density among the expatriates in the right. As we can see in the right upper picture, you can see a crowd outside the business, and many expatriates lived in old houses with limited sanitations. Also, when we visited the company dormitories, we found a high degree of crowdedness in most rooms. We found more than 7 labor per room. And in the bottom right photo, you can see the bunk beds that line the walls of these dormitories. These rooms had at least 8 people living in one room, and workers would smoke and cook inside the room. Several clinical and public health measures were implemented to control the cluster outbreak in Matrah. Lockdown were implemented to slow the spread, and the government also established surveillance of COVID-19 and updated case definitions, so we could have an accurate understanding of the outbreak. A critical intervention was community awareness and engagement, as many expatriates don't speak Arabic or English. We need to find way to engage this high-risk group, so we did we had several meetings with the representative from their embassies to allow us to send text messages in their language about how to protect themselves. Also, for the mass testing, it was critical to identify those cases with mild symptoms or those who may be reluctant to be tested. The isolation of the confirmed cases and quarantine of travelers or contact to positive cases helped to slow the spread also. Throughout the outbreak, it was also critical to ensure the district was able to maintain essential health services for any other emergency care that people may need it.
One more minute, Dr. Asim.
Okay.
Please go to conclusion.
Okay. For our investigations face several limitations as language and culture barriers made it difficult to communicate with the non-Omanis. Also, asymptomatic people were not tested under our suspect or confirmed cases. Also, our case definitions changed during the investigations, and we also had no access to the hospital. For the sake, most of the cases occurred among male migrants within 30 to 60 years because of the contact with the travelers, also worked at the old market or the seaport, and the large-scale interventions lead to the slow the spread by detection and isolation of the cases and awareness of infection control measures. Also, because of the COVID pandemic is far from over, so we recommend to continue with adherence to control measures among the peoples, and also encourage people to undergo testing immediately if they are develop any symptoms, and enhance the surveillance inside Mastrah or outside for the detection of the early cases, and also for the zero survey conducting to estimate the numbers of the cases which was asymptomatic. This is the I would like to thank the following individuals.
Thank you very much. Thank you very much, Dr. Asim. We appreciate your presentation. Please close your sharing, stop your sharing. And I'm going to give the floor now to an interesting survey that was conducted among public health workers to assess their knowledge, attitudes, and practices in the East Mediterranean region. This will be presented by Dr. Salma Afifoui. Dr. Salma, the floor is yours. Please share your content and open your video.
Do you hear me, Dr. Salim?
Yes, good evening. We can hear you. We can see the presentation, but we can't see your video yet.
Yes, my video, okay. Is this okay? Can you see me?
No, I can see your bed. Okay. أهلا وسهلا دكتورة. The floor is yours. تفضلي.
I'm sorry. Sorry, Kevin. Good afternoon, everyone. I'm going to present this presentation on behalf of Dr. Sahar Sami, who is unfortunately unable to attend due to other commitments here. Well, since the beginning of the 20th century, it was obvious that there is a growing need for public health professionals skilled in preventing and responding to disease epidemics to combat the surge of emerging and re-emerging infectious diseases. This need was aggravated by the COVID-19 pandemic, which has significantly stressed public health systems and highlighted the need for a strong public health foundation to combat the pandemic. In our region, many countries are still having limited capacity to face their public health challenges. As we all know, FGTP was designed to build public health capacities by increasing number of field.
Doctora, for the sake of time, maybe you can jump over the slides that are general information and go straight to your results, please.
Okay.
Yeah.
So the objective of this study is to evaluate the role of public health workers in 10 Eastern Mediterranean countries through assessment of their knowledge, attitude, and practice, and in response to the pandemic, and evaluation of the effectiveness of the FGTP in enhancing public health capacity through comparing performance of public health workers who attended FGTP to those who did not. And lastly, to identify strengths and weaknesses in their training and share lessons learned from the current pandemic with other countries. The study is a multi-country cross-sectional conducted in 10 countries in the Eastern Mediterranean region, including Egypt, Sudan, Jordan, Iraq, Afghanistan, Yemen, Pakistan, Morocco, Saudi Arabia, and Tunisia. The study targeted the mid-level public health professionals at ministries of health, governmental public health agencies, governorate, provincial level, and frontline public health workers participated in response to current COVID-19 epidemic. We used stratified technique to involve public health workers at different levels. Data was collected using an online questionnaire developed by Togo Toolbox application. The country principal investigators distributed the questionnaire online to the focal points who distributed the questionnaire and collected the data. The data collection tool has 4 sections. The first to collect is respondents' demographics, the second to test the knowledge about COVID, and the third to assess the attitude towards participation in the epidemic control, and the fourth is to collect data on respondents' participation of COVID-19 pandemic control. The practice section was subdivided into 7 components: surveillance and risk assessment, rapid response, risk communication, public health laboratories, command and coordination, points of entry, and infection prevention and control. We used 0-1 scoring system to evaluate the knowledge, 5 points Likert scale for attitude, and from 0 to 1 scale to evaluate the practice based on participation in the activity and number of times of participation. Descriptive data analysis was conducted to present the demographic data. Means of knowledge, attitude, and practice scores were calculated to compare the demographic data, the scores by demographics. Bivariate analysis weighted by country was performed to compare the mean scores between FGTP trained and non-FGTP trained. Practice scores were converted to percents of total scores for each practice component. We used t-test, ANOVA, Mann-Whitney, Wilcoxon. Multivariate analysis was performed to adjust for confounders. Overall, 1,337 public health workers filled the questionnaire. Almost 2/3 of them were from Iraq and from Egypt. Of the 1,337 public health worker respondents, 62% were younger than 40 years, 63.6 were males, and different occupations have been reported between healthcare professionals, physicians, epidemiologists, and sanitarians. Education, about 38% had bachelor degree, and about 1/4 of them were having a postgraduate degree. They differed in the duration of experience at the public health field at Ministry of Health. This slide shows the mean scores of the knowledge, attitude, and practice of study public health by age. We can notice that the public health workers are more than 40 years of age, are more knowledgeable, and participated more in the epidemic control than the younger workers. This slide compares the knowledge, attitude, and practice of public health workers by gender. We can see that the female public health workers are more knowledgeable. However, the male public health workers are having better attitude and participated more in the control of the pandemic. By level of education, no differences in knowledge and attitude between different levels of education. However, it's clear that higher levels are found, or participation was found in the upper levels of education. By participating country, there was no significant difference in the knowledge and the attitude, but different levels of participation of public health workers in the pandemic control have been identified in different countries. Among the 1,337 public health workers participated in the study, 427 had FGTP training, representing 31.6%. About half of them had advanced level, and about 1/3 having intermediate level of training. This figure shows that most of the FETP trained in the 3 levels were graduated during the last 10 years. This indicates that the FETP programs were enhanced in the Eastern Mediterranean region during this decade. This graph shows the employment of FETP graduates in different levels of public health system. It shows that most of the FETP graduated from advanced and all intermediate levels of training are working at central and in governorate levels. However, many of them are working at district level. On the opposite side, some public health workers who had FETP basic training are working at central level. To compare FETP trained to those who did not attend the training, the FETP trained are older, more males, working in epidemiology and as epidemiologists and sanitarians, are having postgraduate degrees and more experienced in public health.
1 more minute, Dr. Afifi.
Oh,
go to the conclusions, please.
I see. I just wanted to say that the attitude of the FETP trained was better than the non-FETP trained, but the knowledge does not differ greatly, and they reacted. I don't know. I'm not sure. I will be able. There is a lot to say. This graph compares the level of participation. This is important. So the level of participation of FETP trained versus those who did not train. There is a difference, a significant difference between those who had FETP trained versus those who had not in all components of practice. So in conclusion, the FETP at East Mediterranean strengthened during the last 10 years, which is partly attributed to the EMPHNET support. FETP trained were older than non-FETP trained and mostly working as epidemiologists and sanitarians. FETP trained have better knowledge, attitude, and practice scores compared to those who did not attend, but they need more psychological support. The main area, the FETP trained participants are public health surveillance, risk communication, and rapid response. Level of participation was low in points of entry, infection control and prevention, public health laboratories. The KAP mean scores for those attended the intermediate level of training were comparable to those attended the advanced level. So we recommend to maximize the benefit from program. We recommend that the selection criteria should include healthcare providers, younger ages, and emotionally stable candidates. We need to outline a policy for FETP graduate placement at different working levels. We need to expand the intermediate level training to increase the number of qualified field epidemiologists at low resources needed, maintain the rapid response in emergency training, introduce laboratory component in more countries in the Eastern Mediterranean region, and infection control and antimicrobial resistance at healthcare settings and coordination in emergencies are areas where training should include more.
Okay, thank you, Dr. Afifi. We appreciate your presentation very much. Okay, and thanks for sticking with the time. I really appreciate your ability to catch and go. Great. Let's now go to the analysis of risk factors of COVID-19 in the Eastern Mediterranean region, a multi-country retrospective study presented by our colleague and friend, Dr. Faris Lami from Iraq. Tfaddal, Dr. Faris.
Thank you so much, Dr. Adib. Okay, is my screen seen to everybody?
Yes, we can see your screen.
Thank you. Thank you.
And hopefully we can see your video too.
I'm afraid about the bandwidth. It can collapse anytime. Yeah, thank you. So I will talk about our multi-country study that had been done in 7 countries in the EMR region, and I'm going to present on behalf of my colleagues in these countries. So the title here, the risk factor of COVID-19 critical outcomes in the Eastern Mediterranean region, a multi-country retrospective study. We all know that the cases and deaths due to COVID-19 are underreported due to many causes. Among these are probably the inadequate testing facilities, the weak health system response, and inadequate vital registration and the documentation. Also, the high hospital admission and the poor surge capacity of critical care is among the determinants of the poor response for the COVID-19 pandemic in some countries. Also, countries are varied really in the definition of different COVID-19 indicators, testing, and admission policies. To add to these, in fact, in many countries in the Eastern Mediterranean region are suffering from war and political instability, which make them almost peculiar among other areas in the world. In fact, the establishment of empirical evidence in the Eastern Mediterranean region states the implementation of wide-scale studies to describe demographics, clinical features, severity profile of COVID-19 patients. Based on that, this study had come to assess the pattern of COVID-19 severity and mortality in 7 countries and to determine the risk factor of COVID-19 severity and mortality. The study design, as I mentioned, is a multi-country study was based on a retrospective review of medical records of hospitalized patients confirmed to have COVID-19. And these countries include Iraq, Pakistan, Sudan, Somalia, Morocco, Egypt, and Yemen. All data were really extracted from the hospital records, which they were all paper files by trained data collectors. Most of the data collectors were Fgtp residents from these regions, and I'm here to acknowledge their great job. And using a standardized COBO collect form for the data entry. In fact, different settings had been in Iraq, for example, we included 7 hospitals, 6 in Baghdad and 1 in Babil Governorate. In Sudan, 2 main secondary isolation centers, 2 primary isolation centers. In Morocco, Sheikh Zayed International University Hospital of Rabat City was included. In Egypt, Al Agouza Hospital in Giza Governorate was included. In Yemen, 3 main isolation hospitals in Sana'a. In Pakistan, 2 hospitals in Rawalpindi and 2 in Islamabad. And in Somalia, the Martino Hospital in Mogadishu was included. As mentioned, a standardized data collection tool was developed with the agreement of all the colleagues from the 7 countries and converted into COBO toolbox. And this form really composed of 4 parts. So the first part is concerned with the baseline demographics, baseline and demographic characteristics. The second part is concerned with the clinical history and the comorbidities. The third section is concerned with the severity classification, and the fourth is about the outcome. Really, all the definition we depend on WHO guidelines for example, with the history of contact, with the travel history. The severity also classified based on the WHO guideline as a mild dose with upper respiratory disease. Moderate those with pneumonia, but no need for oxygen. Severe is the pneumonia, but need oxygen, and the critical those with who needs ICU admission. Clinical outcomes have been classified into fully recovered, discharge improved, discharge with disability, and death. But practically, in the final analysis, we classify them into 2 groups only. That's survivors versus deaths. Ethical consideration, really ethical approval, have been obtained from the IRB in each particular country, and in addition to approval from the management of each hospital that from which we took the patient's record. And definitely we consider all the confidentiality issues related to these, to the information in these records. All data were coded, and the files were encrypted and saved in a secure database with limited access to a study team. And as mentioned, again, the form was, we use the COBO toolbox for the data entry, and for data analysis, the SPSS was used. And using the standardized statistical test here, but very importantly, I would like to mention that after doing the bivariate analysis, we do a separate multivariate logistic regression in order to identify the significant predictor for both for the severity and for the mortality. And we considered in the final logistic regression only those that had been proved positive, significant in the bivariate analysis. And again, p less than 0.05 was considered statistically significant. The total number of the participant in this study was 4,141. Almost 1/3 came from Iraq, followed by Pakistan, 29%, and Sudan, 24%, and other countries provided with less number of patients. Regarding the age distribution, we can see that the bulk of the cases aged more than 40 years, and this is quite expected because here we are not talking about COVID in general. Indeed, we are talking about admitted patients at the hospital. Interestingly, here we can see that the proportion of male is almost double the proportion of females. Concerning the working as a healthcare worker, we can see that 3.5% only of all admitted cases were a healthcare worker. And for the history of contact with a confirmed COVID-19 patients, we found almost 41% of the patients do have this contact. Regarding smoking history, only 15%, almost 15% were other smokers. As regard to the comorbidity, we can see that almost 50%, half of the patients, they don't have any comorbidity, and the remaining half, they do different types of comorbidity. Some have more than one, definitely, but the most common type of comorbidity was the hypertension, which affects something like 1/4 of the cases, followed by diabetes, 23%, and other comorbidities showed a much less proportion. Regarding the symptomatology, we can see that, interestingly, again, only 3% were asymptomatic, which is really weird why we admit asymptomatic cases. But you all remember that in the beginning of the pandemic, many of the asymptomatic positive, PCR positive were isolated and in many countries in the region. So they are asymptomatic, but they're still being isolated and considered for here. As expected, the highest proportion of the most frequent manifestation, was fever, almost 77%, followed by cough, and again, because those are admitted cases, we almost good proportion of them, more than half of them, they do have shortness of breath. Other respiratory and gastrointestinal, musculoskeletal, and others have been reported with less frequency. Now, coming to the bivariate analysis of factors associated with severity and with mortality, you can see we separated them. And for the sake of analysis, again, for the severity, we reclassify mild, moderate into a single category, severe, critical into a separate category. And as we mentioned, for the mortality, we already divide them into survivors versus death. And these, the mortality and severity have been cross-classified by a number of characteristics, demographic characteristics, and other. And we can see that for example, with the sex, it was not a significant predictor for the severity, but it was for death. And we can see the case fatality rate for males is 19.3 compared to 15 or 16% among female. And the difference, as you can see, is statistically significant. Again, there is a clear increase in the severity with increasing age. Those response pattern, 28, 29, 50, and 67 almost for the severity. And again, this is applied similarly for the deaths. With increasing age, there is increasing case fatality, reaching up to 31.3 for those aged more than 60. Again, healthcare workers show less severity and less case fatality, less mortality, and those with positive history of contact, again, this particular variable was statistically significant predictor for both the severity and for the mortality. Smokers, again, they have a higher proportion of severe cases, and it was statistically significant, while it was not, which is really something unexpected, it was not a statistically significant predictor for mortality. For the comorbidities, having any comorbidity really is a significant risk factor for severity, for severe COVID, and for deaths. And you can see they are less than 0.001. And then we use different comorbidities one by one, and we can see that diabetes, hypertension, and heart disease and respiratory diseases, they are in fact a statistically significant predictor of both the severity and the mortality. While some others, for example, with the renal disease, it was a significant factor for the severity, but not for the mortality. On the other hand, CVA was a significant factor for the mortality, but not for the severity. And again, other immune compromised condition was a significant factor for severity, but not for the mortality, while malignancy was significant for both. Based on that,
Dr. Lamy, please try to go straight to the conclusions. Your time is out.
Sorry. Just one point. This is the multivariate analysis, and you can see here again for the severity and mortality, we have some of them that are similar, and some of them they are unique to either the severity or the mortality. So in conclusion, I can say that older patients, men, smokers, and patients with certain comorbidities, particularly diabetes, hypertension, heart disease, COPD, malignancy, and renal disease, were more likely to suffer from severe and/or fatal COVID-19. Based on that, we think that in a hospital setting, healthcare provider should be more attentive to patients with these identified risk factors in order to mitigate the serious outcome. And thank you so much.
Great. Thank you very much, Dr. Faris. I have to apologize again to our colleagues in Afghanistan. I know that they're going through hard times with all their setup, which meant that we could not provide them with enough time to do their presentation. Inshallah, another time we will be able to see something even more complete. I'd like to thank everybody who participated in this panel. I've never worked like this. 10 minutes is not enough in the Arab world, ya Jamia. So anyways, that means that we can entertain probably one or two questions. I'd like to, lots of people have directed a question to Dr. Namir Ali regarding the gender differences in incidence in Iraq. And some of them are saying you're assuming that this is a real difference, and you want to look into immunological and humoral differences between men and women with COVID, but you should maybe discuss the possibility of social stigma with COVID that makes it more difficult for women to come to the clinic and obtain a laboratory test. What do you think about this? Are we looking at a selection bias, referral bias that is sociologically determined? Tfadal.
Yeah, thank you so much. Actually, I think the real cause for this is that women, of course, have so much things to be taken into consideration, especially in our countries, in this part of the world. So socio-economic status affects this very clearly. Yes. I think we need, but I think we need to look after this in more in depth. Yes, thank you.
Yeah, well, maybe use every man as index case for a potential cluster back in their households, and send back a group to investigate everybody else, including the women who cannot get out of the home. Yeah. I think that would be a good idea.
Yeah, I totally agree. Yeah, sure.
There are several other questions. Some of them pertain to the reality of COVID-19 worldwide and maybe not totally relevant to our regional tack. But I found a question from Dr. Ihab al-Saqqaf as being quite challenging. Ihab can be a man or a woman. I'm really sorry. I'm going to say she. No, he, Ihab. Says statistically in Yemen, the cases and deaths are much less than the neighboring countries, despite the low health and economic situations due to war and conflict. What is the reason, in your opinion? Anyone is interested in responding to this question about differentials in the COVID epidemic in Yemen and other countries? Maybe our colleague from Saudi Arabia working in Oman, Dr. Asim Al-Manji. Any idea about what's happening?
I think, in my opinion, I don't know what is about the reporting. Maybe the reporting system. What is the what is the system using there for the reporting for the cases and for the death also?
Yeah, I think that's probably the most probable reason with this all this turmoil that Yemen is going through. Probably people cannot reach testing centers, and even if testing positive, we don't know if the recording of causes of death and what have you is correct. So maybe maybe Dr. Sagaf, you're not going through a lesser problem. You just don't know it. All right. So I think I'm gonna now close this session. Thank you all for participating. Lots of interesting information. I'm looking forward to an expansion and a deepening of the results in future encounters. Thank you for the organizers, and I'm going to pass the floor back to you. Tfaddal. Thank you.
Thank you, Professor Salim. And now we move to the second session moderated by Dr. Rifat Hanna, a medical epidemiologist at CDC. Dr. Rifat, the floor is yours.
Thank you so much. Good morning, good afternoon, good evening, everyone. It's my pleasure to be here at this symposium. My name is Rifat Hanna. I am the medical epidemiologist with CDC, Fgtp. I manage all the countries in the Middle East, North Africa, and Eastern Europe. Without further ado, we'll proceed to our second session entitled Impact and Consequences of COVID-19. Our first presenter is Dr. Batul Yassin from Iraq Fgtp. The title of her presentation is Long-Term Sequelae of COVID-19 Among Recovered Patients. The study was taking place in Baghdad, Iraq in 2020. Dr. Batul, please share your slides and your video. Thank you.
Thank you, Mr. President, and I will share my slides with you. Good day for everybody, and thank you for having this opportunity. I am presenting this research instead of Dr. Shahid for emergency situation. Typically, people recover from COVID-19 after 2 to 6 weeks. But for some people, however, symptoms may persist or recur for weeks or months following recovery. Recently, the National Institute for Healthcare Excellence has classified the COVID-19 into 3 categories: acute COVID, which lasts for up to 4 weeks, ongoing symptoms of COVID from 4 to 12 weeks, and post-COVID syndrome that for more than 2 weeks. The last 2 are together called long COVID. Actually, the incidence of long COVID varied across countries in different studies, ranging from a study of the UK from 10% of the patients that they still experience symptoms after 12 weeks. In Italy, more than 87.4% had at least one symptom remaining after the 60 days, mainly fatigue, dyspnea, joint pain, and chest pain. In Pakistan, 95% of patients reported at least one COVID-19 symptoms: fatigue on the top, poor sleep, anxiety, dyspnea, joint pain, and loss of smell and taste. Even after 6 months, they found that fatigue and loss of sense of smell or taste, as well as other symptoms, were still reported. Another study from China found that fatigue or muscle weakness found in 63% of patients, sleep difficulties in 26%, and anxiety and depression in 23% of patients. In Iraq, no study were done to estimate the prevalence of long COVID, and gaining knowledge on this is very essential to help clinicians determine the high-risk patients and closely monitor the continuation of symptoms in recovered COVID patients, and to provide necessary rehabilitation for them. The objective of this research was to determine the types and to measure the percentage of long-term sequelae of COVID-19 at least 2 months after recovery in a sample of COVID-19 patients from Baghdad city. A descriptive cross-sectional study was carried out in Al-Risafa Directorate of Health, which is responsible for the eastern side of the capital, Baghdad. A total catchment area population is around 5 million population. There are 9 health districts that included a total of 114 primary healthcare centers. A convenient sample of 3 primary healthcare centers were selected, and the study was implemented during the period from November 2020 to January 2021. Regarding the study population, all patients recovered from COVID-19 after a minimum of 2 months following the recovery who are registered at the assigned primary healthcare centers with available contact information, including the phone number, and who accept to participate were considered eligible to be part of this study. A questionnaire was developed and composed of socio-demographic data, disease characteristic, long-term or persistent symptoms perceived by the patient that include the following: cough, fever, loss of sense of smell, loss of taste, sleep disturbance, concentration problems, headache, fainting, memory, tremor, chest pain, etc. The questionnaires was filled by the researcher through the mobile phone call. Data analysis was done using statistical packages for social sciences version 22, and chi-square test was used for statistical analysis of categorical data. P-value of less than 0.05 was considered statistically significant. Ethical approval was taken from Ministry of Health and the research committee. The eligible patients, total numbers were 350 from the selected 3 primary healthcare centers. Yet the respondent was only 239 with a response rate of 68.3. Their mean age was 37.4 years plus minus 14.2 standard deviation. And about 1/4 of them of the recovered patients still having more than 1 complication. This table showed the demographic characteristics and comorbidities of the studied participants. We found that male and female usually equal. For the age group, most of them were less than 40 years of age, and most of their education was college level, and having morbidities was seen in nearly 30% of the patients. Top of them were having hypertension, diabetes, heart disease. Asking about the symptoms or residual symptoms, on the top of the list, they still having headache after 60 days in 25% of the patients, followed by fatigability, pain or spasm in the muscles, joint, and the least was new diagnosis of diabetes mellitus in 3.8 patients, and 56.9, nearly 60% of them, 57% of them, they showed no residual symptom. Distribution of the study group by the presence of residual symptoms and demographic and clinical characteristic. For gender, we saw that although both of them, male and female, they have less residual symptoms, but still this residual symptom, it failed to have a significant association. Whereas age group more than 50 and more usually have more residual symptoms compared to other age group and with a statistically significant association. Regarding marital status, it was found that widowed or divorced have a statistically significant association with having residual symptoms, and smoking, although smokers have more than residual symptoms, but it failed to reach a statistically significant association. Whereas chronic diseases, patients with chronic diseases, they have high higher percentage of residual symptoms compared to those without comorbidities. And for the education, there is no statistically significant association. Those who are treated at hospital and those who are admitted to ICU, intensive care unit, and those who need oxygen were significantly have higher percentage of residual symptoms compared to other. Conclusion, the long-term sequelae after recovering from COVID-19 are not uncommon in Iraq, and a close long-term follow-up after recovery should be considered, particularly for the high-risk patients. Thank you very much.
Thank you so much, Dr. Batul, and thank you for staying on time. Actually, you still have like 1.5 minutes. Thank you so much. And now we'll move to the next presentation titled Contribution of COVID-19 Pandemic in Neonatal, Prenatal Mortality, Preterm Birth Rate and Birth Weight Trends in Jordan. Our presenter is Dr. Iman Badran from Jordan. Dr. Iman, the floor is yours.
Thank you for giving me the chance to talk about this topic, and I hope you can see the screen. And I'm consultant neonatologist who work at University of Jordan at this prenatal center, and I don't have anything to disclose. These are the objectives of the presentation, and I will start with the background. Birth weight, besides the gestational age and sex of the newborn, has a close relationship with infant mortality and its components. The lower the birth weight and gestational age, the greater the chance of death in the first year of life. Birth weight reflects the nutritional, the metabolic conditions of the mother, as well as fetal development during pregnancy. And prematurity is the leading mortality cause in children aged less than 5 years, and it is associated with negative effects on morbidity and mortality. Neonatal outcome rate during COVID-19 pandemic is expected to be affected. And this evidence in Jordan, from this evidence, we know what are the baseline neonatal mortality rate, what are the baseline of stillbirth rate, low birth weight, and preterm rate. So what about the Jordan situation regarding pregnant mother and healthcare accessibility during COVID pandemic lockdown? Jordan is a Middle East upper middle income country with 10 million inhabitants. And the state of emergency and lockdown measures caused several challenges. There were restricted mobility of patients, including pregnant women and medical staff, during the COVID pandemic and its lockdown. There was a lack of accessibility to a diagnostic tool to all pregnant women, and there were further expansion of telemedicine use to guarantee that some pregnant women retain access to healthcare providers and attend regular follow-up appointment. Moreover, round-the-clock access to emergency department was ensured. A cross-sectional survey in Jordan among pregnant women, which was electronic survey with sample size 9,440, showed that if only 4% of women did not receive antenatal care before COVID-19 pandemic, while around 60% of these pregnant women did not receive the antenatal care during the pandemic. There are several studies which attributed maternal mortality during COVID pandemic to their comorbidities. All of the neonatologists, all the public health know that sick mothers who had COVID, the neonatal mortality of these affected mothers are attributed to prematurity rather than infection. Now, what about the neonatal outcome at population level? We found there is little information about how COVID-19 pandemic affect mothers and their newborn babies at population level, not at sick mother. So with the lockdown measures, with growing awareness of infection prevention measures, the hand hygiene, the wearing mask, the distancing, and variable stay-home orders, and with the lack of proper antenatal care, it was important to explore the possible link occurred during lockdown with these changes to certain neonatal outcomes. So the aim of this study is to investigate the possible link between the national lockdown measures and alteration in the neonatal outcome, including stillbirth rate, neonatal perinatal mortality rate, preterm rate, and birth weight at the time of this pandemic at population level to facilitate further studies on the underlying causes. This was a prospective study using the collected maternal and neonatal standardized data, and the data was collected from 5 pilot hospitals from all sectors of Jordan, representative of all sectors of Jordan. These hospitals were 1 teaching hospital, 1 private hospital, and 3 public hospitals. And the data, the source of data was the Jordan Electronic Stillbirth and Neonatal Death Surveillance System, which is a secure electronic surveillance system established in 2019, which collect and reports standardized perinatal neonatal mortality data. And we collect data 10 months, exactly 10 months just before the COVID, before March, before the appearance of the first case, which was before March 2020. And to know the trend, we compare these data with 10-month period during the pandemic from the 2nd March till end of the 2020, the year 2020. So it was 10 months before and 10 months after. We investigate all newborn who were born during that period between 24 and 40 week gestational age. We define the stillbirth, we define neonatal death, and we define the perinatal death. Also, we stratify the birth weight, different birth weight, and different preterm gestation age, as I will say them in the results. We got the ethical approval from the Jordan Jordan's University of Science and Technology, and from the research committee at the School of Medicine at University of Jordan. And for data management analysis, SPSS version 24 was used for analysis of chi-square and multivariate analysis. Now let's go to the results. A total 31,106 babies were included from 29,592 women. Of these, 49.2% born before the pandemic, and 50.8% were born during the pandemic. And we could not find a significant association in the 2 periods with maternal age. Also, there was no significant association with in the 2 time period with the nationality. However, there are higher percentage of women born in delivered, when we looked at the site of delivery in public hospital, 70% during the pandemic, which was 62%. So it was so significant, there was significant association. And this slide shows that higher percentage of women with income less than 500 Jordanian dinar during the pandemic, compared to 79% before the dynamic, and this was significantly, there was significant association. When we look to the multiplicity, lower percentage of single-tone pregnancy occurred during pandemic, and it was significant results. And fewer percentage of nulliparity occurred during the pandemic, 0.7 versus 5.7 which is a significant association. When we look to the trend of preterm, we didn't find any significant association. Before it was 8.9, after 8.6, and even after we stratify the gestational age, we didn't find any significant association. But when we look to the birth weight, there was less very low birth weight babies and extreme low birth weight during the COVID as compared to the area before the pandemic, and it was significant association. And more babies who had appropriate for gestational age were delivered during the pandemic, and it was also
Dr. Iman, you have 1 minute, so please,
Okay.
if you can move to the conclusion.
There was no change in the stillbirth, neonatal death, and perinatal death, and these were not significantly association. When we did multivariant analysis, after adjustment of the socioeconomic demographic, we found that the extreme low birth weight was significantly by 61 lower during the pandemic. So in conclusion, we confirm a significant correlation between the lockdown and reduced extreme low birth weight. This reduction persists after adjustment of socioeconomic factor, and this reduction occurred without increase in other neonatal income, the stillbirth, neonatal perinatal mortality, and preterm birth rate. Variable neonatal outcome trends were reported among very few different published studies during COVID-19 pandemic, which allowed us to compare our result with other results. So the findings of this paper are representative of Jordan and emphasize the importance of having electronic surveillance standardized system, and we recommend using the registry system at national, regional, and possible international level to be used for quick collaborative research, for quick identification of the challenges and implementation of these results. This was a result of collaborative team between
Thank you so much, Dr. Iman,
and medical students. Thank you.
Thank you. Thank you so much for the interesting presentation. Obviously, COVID-19 has impacted everything, including primary health care, preventive medicine, including immunization. I've been attending several presentations, even from outside EMRO region, and COVID-19 is really a mess, is impacting every aspect of healthcare. Our next presenter is Dr. Fuad Khorshid from FGTP Pakistan, and the title of the presentation, Impact of COVID-19 on Essential Immunization Regarding Vaccine Preventable Disease, District DG Khan, Punjab, Pakistan, 2020. Dr. Fuad, the floor is yours. Dr. Fuad?
You are muted, Dr. Fuad. Dr. Fuad, you are muted.
Dr. Fuad? Should we move to the next presentation and come back to Dr. Fuad?
Yes, please, because he is not online now.
Okay, the next presenter is Dr. Yasser Ghalib, FGTP Resident Advisor in Yemen, and the title is Mental Health Impact of COVID-19 on Healthcare Workers in Eastern Mediterranean Region, a multi-country study. We'll give Dr. Yasser 30 seconds to be prepared and ready to share the screen and open his video. Dr. Yasser, are you ready?
Yeah.
Okay, go ahead.
Yeah, thank you. Thank you so much. Yasser Ghalib from Yemen, FGTP. I am going to share you with some information about mental health impact of the COVID-19 on healthcare worker in the Syrian Mediterranean region. Simply, the COVID pandemic is a major global health threat and severely affecting mental health care worker. Healthcare worker is the most vulnerable group at risk for COVID-19. By the end of July 2020, nearly 888 healthcare workers are affected and 30 deaths were reported. Infection were mainly in the woman, 70%, and nurses, 38%, but deaths were mainly in men, 70%, and doctor, 50%. Different studies conducted among health workers in different countries, such as China and Singapore and Italy, showed the prevalence of depression, stress, and anxiety and disaster ranged from 6% to 62%. The study aimed to explore depression and anxiety, stress, disaster, and prevention, and assess prevention behavior among health workers to COVID-19 in IMRO, determine the factor associated with this mental health illness, and also provide recommendation for policymaker to planning intervention to protective healthcare worker. A multi-country cross-sectional study was conducted during July to August. The study involved various healthcare workers, such as physician, nurse, and pharmaceutics, and radiology technician and laboratory technician working at teaching and public and private hospital of selected countries. The hospital were selected according to finding of primary and secondary COVID isolation center and located in a hotspot with COVID outbreak. Data were collected using online questionnaire administered in the collector box. It included the questionnaire regarding socio-demographic characteristic and medical history, exposure to COVID-19 and emotional status for depression, anxiety and stress and stress level, work from COVID skills. Depression, anxiety, distress skills was used to measure the emotional status of the mental skills. Analysis of the data was performed by using SPSS and the result were expressed as figure and table. Multivariate regression analysis were carried out to determine the predictor of the mental associated factor of COVID and Cornbach alpha test used for reliability analysis. P-value less than 0.5 was considered statistically significant. Our result, this figure shows the distribution of a health worker. A total of 48 of the participants enrolled in this study, most of them from Iraq, Egypt, and Somalia, and Sudan, and Yemen. In this table shows the demographic and the clinical and the work characteristics of the participants, where more than 50% were male and less than 13 years and were married status and reported having children. 2/3 of healthcare workers was working in ministry health hospitals, and 1/3 of non-practitioners were general practitioner, and 30% were nurses. Also, most of participants were non-smoker and only sleeping less than 7 hours and live with family members. And most of participants regarding of chronic disease have had hypertension. About 400% of healthcare workers work as a frontline role, have had frontline roles, and 30% were infected with COVID-19, and 30% were isolated due to the COVID, and about a third of participants had family members infected with COVID. Only 8% had family members died with COVID. About 80% had a friend and colleagues infected with COVID, and only 25% had friend colleagues just died. In this figure, in this table shows the summary statistics of depression, anxiety, and stress, and COVID-19 worry skills. Cronbach alpha was satisfactory for all skills and exceeded 0.80. In this figure, we can show we can show about 57% had depression and 42% of the participants had stress and about 60% had anxiety. Considering the severity, 90% and 60% and 26% of the participants had anxiety and depression and stress respectively. In this table, we can see multivariate analysis of the factor associated with depression, anxiety, and stress score. There were significant variation in the three skills scan between healthcare worker according to country. Healthcare in Egypt and Iraq and Sudan had the highest depression, anxiety, and stress score compared to health worker in other countries. Female had significantly higher depression and stress score than men. Healthcare worker in private hospital had a relatively lower depression and stress score compared to those working in the Ministry of Health and Teaching Hospital. Specialists and general practitioners had the highest score when compared with other healthcare worker. Healthcare worker with children had a significantly higher depression and stress score than those without children. In this table, participants who have a preexisting psychiatric illness have been isolated and has been isolated due to COVID, and having a friend or colleague infected with COVID and increased COVID worry scoring were significantly associated with higher depression, stress, and anxiety score. In this table, we can see the multivariate analysis. There are significantly variation in different score among healthcare workers according to the countries. Jordan healthcare worker has the highest distress score. Radiologist technician the highest distress score, and female and married participant. In this table, smoking and diabetes have apparent colleagues died with COVID-19 and higher COVID worry score were significantly associated with higher disease score. Conclusion and recommendation: healthcare workers responding to the spread of COVID-19 expressed moderate to severe mental impact and reporting high score of stress, depression, anxiety, and stress symptoms. Special intervention we recommended to implement immediately implemented with special intervention to prevent mental health pain, to protect the healthcare worker, specialist woman, specialist doctor, and general practitioner for frontline worker requiring particular attention, increase public health awareness regarding associated factor of the stress, and ensuring more research should be considered. The result may be help policymakers and healthcare workers to manage male addictive levels for fear and worry due to the COVID outbreak. Thank you.
Thank you so much, and thank you for being on time. One of the interesting findings that married participants had higher stress. I'm not sure if it is because of COVID or the marriage itself. So probably this will need we need a study. Thank you so much.
Thank you.
Our next presenter is Dr. Fuad Khurshid from Pakistan Fgtp. And the title of presentation is Impact of COVID-19 on Essential Immunization Regarding Vaccine Preventable Disease. The study was conducted in District DG Khan, Punjab in Pakistan 2020. Dr. Fuad, the floor is yours.
Assalamu alaikum. Can you hear me?
Yes, we hear you. Okay. But we don't see your PowerPoint.
Good evening, everyone.
Iman, would you please share the presentation?
Go ahead, Dr. Fuad.
Good evening, everyone. I am Dr. Fuad Khurshid, graduate from Fgtp, Pakistan. And today I am going to present my research work on impact of COVID-19 on essential immunization regarding vaccine preventable diseases in district DG Khan, province of Punjab, Pakistan, 2020. Next. Children are immunized for 10 diseases in routine EPI expanded program on immunization scheduled before 23 months of the age. These 10 diseases are poliomyelitis, tuberculosis, diphtheria, tetanus, pneumonia, hepatitis B, meningitis, diarrhea, and the measles. Routine immunization coverage in Pakistan is 67.5%, while in Punjab province it is 64.1%. Pakistan has showed the little progress in achieving the immunization coverage of 90% by the year 2020. Next. This is a map of Pakistan showing DG Khan. It is located in the almost center of the Pakistan. District DG Khan is located in the southern Punjab province, and epidemiologically, it is one of the high-risk districts of the Pakistan because it is connecting all the 4 provinces of Pakistan, having boundaries with Balochistan and KPK provinces, and entire eastern boundary of the DG Khan is riverine, while its western boundary is mountainous Kohi Suleiman, and this mountainous terrain is covering 53% of the total area of the whole district. Next. And if you can see, these 5 unit councils of the DG Khan are bordering with Balochistan province, and 2 are bordering with KPK province, and these are tribal. These pink highlighted uses are the tribal uses. Next. This study was carried out to assess the impact of the COVID-19 on essential immunization status of the children during 2020 in district DG Khan, and to make the suggestions for strengthening of the essential immunization. Next. The objective of this study was to assess the essential immunization coverage in the children less than 2 years of the age during the years 2019 and 2020 in district DG Khan, and to formulate the recommendations for the strengthening of the essential immunization during the COVID-19 pandemic. Next. Next. Next, please.
Dr. Fawad, please look at the presentation. We are showing
Next,
now
please.
the results. Dr. Fawad, we are showing the table, the figures for you now. Look at the presentation.
Impact of COVID-19 on essential immunization status of the children during 2020, during the month of January 2021, and data was collected for 2019 and 20 months.
Dr. Fouad, the slide now is BCG and OPV3 coverage.
The BCG is given after the birth and during the April 2020 during the COVID-19. Yes, for the month of April. Yes, BCG coverage during the month of April 19 was 107%, while during the April 20, during the COVID-19, it was 83%. Similarly, the OPV3 coverage during the month of April 19 was 96%, while during April 2020, it was 93%. Next. Can we move to the next slide? BCG coverage during the month of May was 111%, while it was 79% during the month of May 20. Similarly, the OPV3 coverage during the month of May 19 was 99%, while it was 72% during the month of May Pentavalent is given at the age of 6, 10, and 14 weeks. So the Penta 1 coverage during the March 19 was 95%, while during the March 20, it was the first month for the start of the COVID pandemic. It was 56%. Penta 2 coverage, it was 98%, while it was 53% during the month of March 2019 was 96%, while in March 20 it was 40%. Pentavalent coverage comparison during the April 2019, during April Penta 1 coverage was 95%, while during April 20 it remained only 3%. Penta 2 coverage was 98% during the month of April 2019, while it was only 2% during April 20. Penta 3 coverage was 96% during April 19, and it was 2% during the month of April 2020. Pentavalent coverage comparison during the month of May 2019 and 2020. Penta 1 coverage was 97% during May 19, and it was 81% during May 19, and it was 74% during the month of May 20. Penta 3 coverage was 99% during May 2020. Measles 1 is given at once. Measles 1 coverage was 94% during March 2019, while it remained only 68% during March 20. Measles 2 coverage was 93% during the month of March 19, while it remained only 67% during March 20. Similarly, if we look at Measles 1 and 2 coverage during the April 19 and 2020, there is marked downfall in the coverage of Measles 1 and 2. And during the May, Measles 1 coverage was 100% in 2019, and 2020 it was 83%, while during the May 2020 Measles 2 coverage remained only 77%. Tetanus toxoid vaccination TT1 and 2, it is given in rural areas 7th and 8th month of the pregnancy. TT1 during the month of March 19, while it remained only 57% during the month of March 2020. TT2 coverage was 82% in March 19, while it was 42% during the month of March 20. Similarly, during April 2019 and 2020 comparison, if we look, TT1 coverage was 90% during April 19, while it remained only 67% during April 20, while in April 19, it was TT2 coverage was 84% and 54% in April 20. You can see the marked difference. It was 69% only TT1 coverage during May 2020, while TT2 coverage was 56% during the month of May 2020. Conclusion, the main reason was the essential immunization activities were affected badly during the first 3 months of the pandemic. March in Pakistan was notified on 26th of February. Major reason for low coverage was the community fear, and parents were refusal for vaccination because of COVID-19. Even the parents had misconception in their minds that the vaccinators are injecting the poisonous injection, so their kids may die. Even they were reluctant to go for the center hospitals for vaccination because they had in their minds that they will get the COVID-19. Similarly, all the antigen coverage remained low during the first 3 months of the
Dr. Fuad, you have less than 1 minute.
So it was recommended that outreach sessions for the immunizations need to be carried out on regular basis by following the COVID-19 SOPs like use of the face masks and hand sanitizers by the vaccination staff. Social mobilization activities for the parents about the vaccination was recommended. Regular community awareness sessions for building the community trust are recommended. because the people had misconceptions in them. Essential immunization was recommended, and availability of the vaccinators led the health workers should be ensured through regular supervision and monitoring. Impact was that vaccination staff is 100% following the COVID-19 SOPs during the vaccination so that they make clear the misconception of the community regarding vaccination. Regular monitoring and reporting of the vaccinators by the supervisory staff has been started by the district office, and enhanced social mobilization activities have been started for building community trust for vaccination during COVID-19 pandemic.
Dr. Fahd, thank you so much for the wonderful presentation. Thank you so much. Before we move to the next presenter, which I'm not sure if the presenter is online, I just got a note on the chat side that it looks like Dr. Mohammadi Dilal from Tunisia is not online. We'll check later, but I would like to remind the participants, if you have any questions, please post them in the Q&A box. So far, we don't have too many questions, only like 3 of them. But if you have any questions to any of the presenters, please post them on the Q&A box. Now we are at the end of this session, and the last but not least presentation by Dr. Mohammadi Dilal, Fgtp graduate Tunisia, and the title of the presentation, Early Impact of COVID-19 Pandemic on Routine Childhood Immunization, Coverage Rates in Kasserine District, Tunisia, February to April 2020. Is Dr. Mohammadi online?
Dr. Rifat, it seems to us that he is not online, and actually he did not share his presentation.
I see.
Doubt that. Yes, sir.
Okay, so this concludes our session. I have just a few questions here on the Q&A box. One of them is to Dr. Fouad from Pakistan. The question is, what is the situation of routine immunization and polio in Balochistan? And how about outreach program in mentioned area? Dr. Fouad, did you hear the question? Dr. Fouad? Dr. Fouad Khurshid? Your signal is very bad. We cannot hear you. We cannot hear you. Unfortunately, the signal is too bad. I will come back to you with the question.
Province of Balochistan. The routine immunization in province of Balochistan is very low in compromised areas.
Yes, we hear you now.
Can you hear me?
Okay, Dr. Abdul Shakur Nasrat, does that
Can you
answer
hear
your
me
question?
now?
We can take the next question.
We can. Well, most of the questions are for Dr. Fouad. The second question from Dr. Islam Saeed.
Can you hear me now?
Yes, we hear you now, but it's on and off. Okay, I will move to the next question, then we'll come back to Dr. Fouad regarding Balochistan. The question is from Dr. Islam Saeed. He's asking if there is some other waves of COVID-19, how to manage the immunization and other essential activities. this is open question to everyone who wish to answer this question, any of the presenters. The question again, if there is some other waves of COVID-19, how to manage the immunization and other essential activities? Okay, I can provide some answers based on my humble knowledge. Now? Dr. Fuad, your voice is on and off, and really it's cutting out. Anyone wants to answer this question?
Okay, I'm typing down.
I'm sorry? Okay, another question from Dr. Islam Saeed is how to use the vaccination opportunities to enhance the COVID-19 vaccination or vice versa.
Can be answered by any one of the speakers.
Yeah. Any participant who wants to volunteer and answer this question, it's an open question for everyone.
يعني احنا Dr. Rifat, we will make sure that all questions are answered and will be disseminated on using our symposium report. So we will make sure that all addressed.
Okay, that sounds very good. So just a quick question also from my side, since I have the microphone. I noticed that there is a big variation of different type of vaccines, although most of them are given on the same session. Is there any explanation why we see a variation between measles, polio, BCG, although most of them are given at the same session? Probably Dr. Yusuf, anyone can answer? Since Dr. Fuad.
Can you please, can you repeat the question, please, Dr. Rifat?
Sure. During the presentation of Dr. Fuad, we noticed that there is a big variation in the in different vaccines, like measles, different from polio, from BCG, although most of those vaccines are given at the same session. So why do we see this variation?
Okay, Dr. Rifat, it seems that we will get the answers, for all the questions. So we might move now to next session.
Thank you.
Yes,
okay, thank you so
Dr.
much.
Rifat.
Thank you.
Thank you. Thank you, Dr. Rifat. With this, we have come to the end of the first day of the symposium. I would like to extend my thank you to all our guests and speakers for participating in this event. We are grateful for your time and insight, and we look forward to seeing you all tomorrow at the same time. And now I hand the floor to Dr. Muhannad Ansur if he has some closing remarks about the first day.
Thank you. Thank you very much. Actually, I have just to thank you all for attending today. And we hope you found the session beneficial. And if you allow me, I wanted to thank especially the keynote speaker, Ron, for very interesting presentation, and our moderators, Dr. Fad Salami, also Professor Salim Adib, and Dr. Rifat Han. And I would like also to thank all presenters for their presentation, and the audience for their contributions and the questions they shared. I hope to see you all, inshallah, tomorrow at the same time, and wishing you very good day. Thank you very much. Thank you.